We're going to go ahead and start with Grand Rounds today. We're excited to have Dr. Chambers here to bring us up to date on advances in treating COPD. We have also added podcasting to these lectures, so they will be recorded and available on Moodle. And thank Dr. Chambers for being with us today.
Thank you very much. So I chose this topic because COPD is something that we see very commonly in this region. Louisiana actually has the third highest smoking rate in the nation among states. And I'm sure that all of you run into these patients in clinic. And previously, beyond inhaler medications, we didn't really have much for improving people's quality of life beyond a certain point. But over the past few years, we've seen the approval of a few systems for patients with emphysema, and now there is a promising new therapy coming up for patients with chronic bronchitis who have never really responded well to the previous treatments that we've had available. So right now is a pretty exciting time in the field of COPD, and so I thought it would be good to go over a review of the diagnosis and treatment and then talk about some of the new things that are available and coming down the pipeline. So I have no conflicts of interest to disclose in this discussion. So we're going to start a little bit about what COPD is, do a quick review of how it's diagnosed, and then talk about some of the classical non-pharmacologic and pharmacologic treatments of the disease. And then we'll talk about advanced disease and some of the new treatments that are coming along. All right, so Gold 2019 defines COPD as a disease characterized by persistent respiratory symptoms and airflow limitation due to airway and or alveolar abnormalities, usually caused by significant exposure to noxious particles or gases. Now, the chronic airway inflammation leads to neutrophilic inflammation and overproduction of goblet cells, hyperproduction of mucus, and that leads to the clinical condition that we call chronic bronchitis. On the other hand, the alveolar destruction leads to loss of airway transfer surface and formation of large, deformed air sacs, and this is the pathologic process that we call emphysema. And most patients will actually have some mixture of the two. Patients will fall somewhere on a spectrum between these two pathologic entities. So what are the major contributors to COPD? Well, as we've already mentioned, tobacco smoke in the United States, biggest contributor. One thing that has been increasingly recognized over the past decade, particularly in developing countries, is the contribution from indoor airway pollution. And this typically comes from the burning of biomass as fuel, a lot of the times for indoor cooking. We can see occupational exposures, including both organic and inorganic dusts and noxious fumes. And then there's genetics involved. Probably the most well-known genetic variant is the alpha-1 antitrypsin deficiency. However, there are some other genetic variants that appear to be associated with an increased risk of developing COPD with the appropriate stimuli. Your risk goes up with age. Women are at higher risk than men given the same amount of exposure. And then patients with HIV are actually at increased risk compared to the non-HIV infected population, again, controlling for the same amount of exposure. Standard symptoms, most common complaint that we hear is dyspnea, typically progressive, typically worsens with exertion. Patients will frequently complain of a chronic cough. This is one of the major things on the differential diagnosis for chronic cough. Classically, with chronic bronchitis, we talk about that cough being productive, but patients with significant emphysema can also complain of a chronic non-productive cough. And they may also describe a sensation of persistent wheezing or tightness in their chest, increased sputum production, and we see recurrent respiratory infections. And then one other thing that I wanted to bring up that a lot of the times we forget about is that while COPD starts out in the lung, because of the chronic inflammation, we do see significant extrapulmonary manifestations of the disease. So cachexia and sarcopenia are very common. So interestingly, even though this can improve with pulmonary rehabilitation, even if you do a lung transplant on these patients, a lot of their muscle function and their weight typically doesn't return to their pre-disease baseline. We also see an increased risk of atherosclerotic vascular disease, including myocardial infarction and stroke. And we see this risk independently of their smoking history, their age, and their gender. So this isn't just a result of the exposures that led to COPD. There's an added risk from simply having COPD itself. Other things that we see from this, osteoporosis. Contrary to what we're often taught, we actually more commonly see anemia than polycythemia with COPD. And this anemia will typically take the form of a normochromic, normocytic anemia that we typically associate with chronic inflammatory diseases. And then depression is a major problem with COPD patients as well. Partly related to the degree of disability, but also partly related to simply having a chronic inflammatory state. COPD, as far as diagnosis, it should really be suspected in any patient who is coming in with progressive cough, dyspnea, or chronic sputum production. And as part of our history, we really do need to do a very detailed social history. So including any exposures to burning biomass, a detailed tobacco history. Because remember, people can smoke different amounts at different times throughout their life. They may be smoking 2 or 3 cigarettes a day now, but if you dig a little deeper, they may be coming off many years of smoking 2 or 3 packs a day. And then taking a very detailed exposure history as well. So what kind of jobs have you done? What sort of exposures did you have during these jobs? Do you work any hobbies that include burning organic matter? But as far as the diagnosis goes, spirometry is really mandatory. So according to the GOLD criteria, we define COPD as a ratio between the 1 second forced expiratory volume and the forced vital capacity of less than 70%. And this should not completely reverse with bronchodilator administration. So once we've diagnosed COPD, we need to talk about severity. And what's a little bit more useful to me than the degree of airflow obstruction is actually how the patient feels, what their functional status is. And so a lot of the predictive models that we use are based on the Modified Medical Research Council scale for dyspnea. Getting a clear idea of what they're able to do is important for determining their prognosis, and it really determines how aggressively you're going to treat the patient. The question that I tend to ask people is, when you're at your baseline, what is the most strenuous thing that you are able to do before you have to stop and rest? I'll often specifically ask about things like stair climbing, walking on level ground, walking on an incline. Do you have to slow down when you walk, or can you keep up with other people, your age, who are generally healthy? And one of the things that really is the most ominous to me is when people tell me they get dyspneic when they're talking too much. They get dyspneic showering. They get dyspneic putting on their clothes. So these are people who have a poorer prognosis and who have a significant amount of debility due to their condition. So we also now talk about GOLD groupings. This is from the GOLD 2019 guidelines. And this really functions on two axes. The first is that MMRC, so the degree of dyspnea that they experience at baseline. And then the other is how many exacerbations they're having per year. And there's different treatment recommendations depending on which GOLD group a patient falls into. I'd say most of our patients that we see in clinic fall under either group B or D, depending how often they're having exacerbations. I very seldom see people fall into group C. I think we maybe have one or two in clinic. And then group A is where we want people. So these are people who are doing well, not having exacerbations. And then as far as long-term mortality, what we have to predict that is the Bodie index. So this kind of takes a lot of the real adverse prognostic signs and puts them into a score. So higher score, greater risk of mortality over the next 3 years. And so in this, you see that the degree of airway obstruction is really only one of the variables involved. So we also look at how dyspneic they are, how far they can walk on a 6-minute walk test, and then do they have significant malnourishment, or are they significantly underweight? So as far as general non-pharmacologic treatment measures for COPD, the thing I cannot stress enough for this is smoking cessation. This is, if you take all comers, the only thing that will uniformly reduce their risk of death. So in the lung health study back in 2000, they saw that the rate of yearly decline of lung function was cut in half in patients who quit smoking. And that 31 milliliters per year is the rate at which people over the age of 40 will lose lung function just due to normal aging. So basically, you quit smoking, you stop the damage that is happening to the lungs due to the smoking. So they'll continue to decline just because of normal aging, but they won't have that additional decline from smoking. So another analysis of these data was published in 2005, and this was looking over about 14.5 years. And this was looking at...
The conference is about to end.
This was looking at the effect of just a smoking cessation counseling and nicotine replacement. What they saw was that just offering counseling and nicotine replacement dropped the risk of mortality by an absolute value of about 15%. And this was with just under 22% quitting in the intervention group versus about 5% in the control group. Among those who successfully quit, they reduced their 15-year death rate by 47%. So significant treatment effect from smoking cessation. So as far as oxygen goes, we often put a lot of our patients on oxygen. The typical medical practice is that we do a walk test to see if they have desaturation with exertion. One thing that I want to point out here is that the people who have actually shown mortality benefit from oxygen are only those who have significant resting hypoxemia. So that's a saturation of less than 88% on room air. And this was 2 trials, one done in Europe, one done in the United States. So in order to answer the question of whether moderate hypoxemia is a problem or hypoxemia with exertion is a problem that would benefit from oxygen therapy, the long-term oxygen therapy trial was performed, and this was published in the New England Journal in 2016. 738 patients. The biggest weakness was that they actually changed the protocol partway through because they weren't getting enough people who only had the moderate resting hypoxemia. So they changed to include exercise-induced hypoxemia. No significant benefit in this group of patients. And interestingly, we usually think of oxygen as a benign intervention, but there were adverse events related to the oxygen. In particular, there were actually a few fractures from people tripping over their oxygen equipment or their oxygen tubing. So we always have to remember, these are not necessarily benign interventions that we're doing. So we really have to rethink things that don't have significant value. However, the value of oxygen with severe resting hypoxemia is unquestioned. So nocturnal non-invasive therapy. The current data are conflicting with this, but right now the balance of evidence does suggest that in appropriately selected patients, placing them on non-invasive positive pressure ventilation at night does have some benefits. So the 2 trials that really did show significant benefit, the first one was the one published in 2014 in the Lancet. This was patients who had stable COPD and resting hypercapnia. And they actually targeted the amount of positive pressure ventilation that they were given to get either a 20% decrease or a PCO2 less than about 48. The reason that you have 51.9 and 48.1 is that they were actually using metric units. So this is translated over from the metric. So 12% mortality in the intervention arm versus 33% in the control arm. Later, 2017 study published in JAMA, this took people 2 to 4 weeks after an exacerbation requiring non-invasive positive pressure ventilation. And here they actually did an in-hospital titration. And they were using transcutaneous PCO2. And in this case, they were using a combined outcome of time to readmission and combined readmission or death. And they did show a significant improvement in both of these outcomes. So one of the therapies that any of our fellows will recognize if they've worked one time in clinic with me is pulmonary rehabilitation. So what this is basically an intervention including aerobic exercise, strength-building exercise, and then a multitude of behavior exercises. They also do oxygen titration. They do smoking cessation counseling, and it's really geared at an overall improvement in functional capacity, and in quality of life. There's been a few Cochrane reviews on this, focusing on different questions. So in the general population, we do see a significant improvement in healthcare-related quality of life and in all measures of exercise capacity that they looked at. Did not really see a significant difference between exercise-only programs and programs that include the behavioral training and psychologic training. In 2016, they looked specifically at patients who had just had an acute exacerbation of COPD. Again, improves healthcare-related quality of life, improves exercise capacity, and they found that it's safe after an exacerbation. There had previously been some questions as to whether, if someone had just had an acute exacerbation, can you safely send them through pulmonary rehabilitation? And the general consensus based on this review is yes, you can safely send them. There was some possible effect on reducing readmissions. Results were not consistent across the studies that they looked at. So our patients with COPD are generally going to require pharmacologic treatment. So general principles of pharmacotherapy, we start out with inhaled medications. Goal of therapy is really reduction of symptoms and improvement in quality of life and prevention of exacerbations. No medication has ever been shown to reduce the risk of death from COPD. In general, short-acting agents should be used on a PRN basis. So we see some people come in who are using scheduled albuterol nebulizers and scheduled ipratropium nebulizers. So for scheduled therapy, you should be using the long-term bronchodilators. And short-acting bronchodilators are for relief of acute symptoms. Even patients without significant bronchodilator reversibility can see benefit from inhaled bronchodilators. Part of the reason for this is that bronchodilator testing is generally done at rest. And some physiologic studies have shown that the change in airway obstruction at rest does not predict the actual effect that bronchodilators will have when people are exerting themselves. So our workhorses are our long-acting bronchodilators. These include the long-acting beta agonists and long-acting muscarinic agonists. Both classes do improve FEV1, they do improve symptoms of dyspnea, and they do reduce the risk of exacerbations. Now, in the latest review, which was in 2018 of the literature, if you're looking at monotherapy, the long-acting muscarinics do appear to be superior to the long-acting beta agonists in decreasing your moderate to severe exacerbations in both high and low-risk patients. Combination of the two in high-risk patients is superior to either one of them alone. As far as inhaled corticosteroids go, so combination inhaled corticosteroid plus a long-acting beta in high-risk patients is inferior to the dual long-acting bronchodilator combinations. Plus, your inhaled corticosteroid preparations may lead to an increased risk of pneumonia in these patients who are already at increased risk of significant pulmonary infections. That being said, in people who do have a history of childhood asthma, the addition of an inhaled corticosteroid may be a reasonable initial choice. There's some talk in the GOLD guidelines about using serum eosinophils to predict responsiveness to inhaled corticosteroids. I couldn't really find good literature on that. It's something that would warrant further research. In our most severe population who are having frequent exacerbations with moderate to severe COPD, there is evidence for adding the inhaled corticosteroid onto your long-acting beta and long-acting muscarinic combination. And unfortunately, we do see reduction with this in moderate to severe exacerbations. We do see improvements in FEV1 and improvements in quality of life. So unfortunately, we do end up having to escalate a large percentage of our population to triple inhaled therapy because they don't get to an optimal quality of life, and they continue to have exacerbations even on dual bronchodilator therapy. So roflumilast is one of the newer medications. It's a selective phosphodiesterase 4 inhibitor. Really has very modest benefits. So you can see the difference was about 0.2 exacerbations per year, and only about 50 milliliters improvement in FEV1. And this was in over 3,000 patients. Also has significant adverse effects. The thing that people complain to me most about when I've put them on it is diarrhea. But people also see nausea, weight loss. More people are going to have to stop roflumilast if you start them on it than any of the inhaled therapies. But if you have someone that you kind of need that extra boost to try to keep them out of the hospital, it is something that can be considered. So chronic antibiotic therapy is another thing that we sometimes use for our patients who have frequent severe exacerbations. This also does have a statistically significant but modest effect on the rate of exacerbations. What's generally been studied is chronic macrolide therapy. Again, doesn't change the risk of mortality, doesn't change the rate of lung function, doesn't cause any improvements in lung function. Also, when you're giving chronic antibiotic therapy, one thing that comes up is the question of resistance. And so when you're evaluating patients for chronic antibiotic therapy, one thing that you have to consider in the back of your mind is what's the risk of developing antibiotic-resistant organism colonization versus the risk of this patient coming back to the hospital frequently with significant COPD exacerbations. With that, I'm going to move on to advanced disease. So the oldest therapy for advanced disease, aside from lung transplantation, which can be an entire lecture in and of itself, is lung volume reduction surgery. So what this entails is sequential wedge resections of the worst involved areas of emphysema, with the goal of removing between 20 and 35% of the diseased lung. And this can be done either via median sternotomy or, in more modern times, through VATS. So the data for this basically goes back to 2003, the National Emphysema Treatment Trial. It was done at 17 U.S. centers, and it was just over 1,200 patients. They were randomized to either control, which was best medical care at the time, or bilateral wedge resections to obtain 20 to 35% resection of lung volume. So overall mortality did not change. However, in subgroup analysis, when they looked at the patients with upper lobe predominant emphysema and low exercise capacity, the total mortality did show a statistically significant benefit. In patients with upper lobe predominant emphysema, regardless of their exercise capacity, they did see a significant improvement in exercise capacity. This improvement was also seen in patients with non-upper lobe predominant emphysema who had a low exercise capacity. Now, it's notable that the 90-day mortality rate from the operation itself was just under 8%. So you're talking about an intervention that, while in carefully selected patients does over the long term have benefit, you're accepting a significant upfront morbidity and mortality. So there was an interim analysis of this trial done in 2001 that was published, where they had identified a subset of patients who had a very high risk of mortality from this procedure. And those were the patients who had either an FEV1 less than 20% predicted and either homogeneous emphysema or a DLCO less than 20% predicted. And in these patients, the 30-day mortality rate was 16%. And the long-term mortality rate was significantly higher than any of the other groups. So because of the significant long-term morbidity and mortality from lung volume reduction surgery, we've been interested in looking at ways of less invasively reducing this lung volume hyperexpansion. And what's recently become available is bronchoscopic placement of one-way valves. And I'm going to go over a couple of these systems next. So these are some pictures of the Zephyr valve system. So these are the 3 different valve sizes, and here they are in a standard lung. You can see that they have a one-way valve right here. And as someone's breathing, these kind of open and close like fish mouths so that air is able to exit the targeted lung, but it's not able to enter. One thing that always caused issues with these valve systems previously was what's called collateral ventilation. So we typically learn that the lungs have separate anatomic lobes and fissures that are dividing them. The problem is that in a lot of people, these fissures are not complete. And so even if you block off the upper lobe, you can still be receiving ventilation from the middle lobe. If you block off the lower lobe, you can still be receiving ventilation from the upper lobe across these incomplete fissures. And so what Pulmonex, the makers of the Zephyr valves, have done is created a system called Chartis. And these are 2 graphs from the Chartis system. So this graph, so what you do is you occlude the airway with a balloon that has a pressure and flow measuring device immediately distal to that balloon. If you have collateral ventilation, so the orange shows flow and then the blue shows pressure. So if you have collateral ventilation, you have persistence of flow even after you have occluded off the targeted lobe. Whereas if you do not have collateral ventilation, you see the flow decreases to approaching 0. In the studies that have been done so far that have shown benefit to this system, they've shown benefit in patients who have this bottom tracing. The other major valve system that we have is spiration. This is the one that we're currently using at this center. So their valves are designed like an umbrella. You have these struts here which hold the valve in place in the airway, and air flows out around the umbrella device. But if air tries to flow in, again, that umbrella expands out and stops the air from getting into the bronchus. These are sized using a special measuring balloon. So you have a special deployment catheter that you set. And then this is what the valve looks like when it's deployed. And this post just allows you to easily remove the valve if you have to do so. When we use these for persistent pneumothoraces and persistent air leaks, we generally remove them after about 6 weeks after the lung is healed. There are some indications for valve removal when these are used for COPD, and so having that strut there facilitates removal in those situations as well. Okay, so the studies that have been done on these symptoms, or on these systems. Liberate trial published in 2018. So this one used the Zephyr valve system. They ended up enrolling about 190 patients. And these were patients with severe to very severe airflow obstruction. But they all had increased residual volume, and they had to have increased total lung capacity. These patients had to have gone through pulmonary rehabilitation prior to being admitted into the trial. And they had to have a 6-minute walk distance of at least 100 meters. They selected the target lobe based on the heterogeneity of the emphysema on high-resolution CT. And then during the procedure, they would perform a Chartis balloon occlusion of the target lobe to determine the existence of collateral ventilation. It was only after they determined whether or not collateral ventilation was present that they would then go ahead and randomize patients. And there were about 60 patients in this study that were excluded at the time of procedure because they were collateral ventilation positive. So primary outcome was the percentage of patients showing at least a 15% increase in FEV1. That primary outcome was met. They also showed significant improvements over control in 6-minute walk distance and quality of life. Of note, this was an open label study. Everybody in this study underwent bronchoscopy, but those who did not receive valves would be discharged immediately, and those who did receive valves were kept for observation for a period of 5 days. And the reason for the observation period is the major complication, and this is pneumothorax. Happens a little bit over 25% of the time. Now, in this study, majority of these patients who had a pneumothorax did require chest tube placement, and a little over a quarter of those who had a pneumothorax actually did require removal of at least one of the valves in order to stop the air leak. And they actually had 3 deaths that were related to these pneumothoraces. So I did my fellowship at the University of Louisville while they were participating in this study, and I think we had one patient who had a pretty catastrophic pneumothorax. So this is, again, not a benign intervention. Now, most patients who have a pneumothorax do end up doing well, but this is a significant concern with this procedure. So we go over to what's a little more interesting for this institution, because this was the study that our institution participated in, the IMPROVE trial. This was utilizing the spiration valves. Ended up recruiting 172 patients. They could have slightly less severe emphysema and a slightly lower residual volume. Still had to have a 6-minute walk distance of over 150 meters, but they had to be having significant symptoms. So for this, they selected the target lobe based on both the heterogeneity of the emphysema and a high-resolution CT scan evaluation of the integrity of the fissure between the target lobe and the non-target lobe. They required the fissure to be at least 90% intact. In this case, the primary outcome was the difference between control and intervention group in improvement in FEV1. And the study met this primary outcome at both 6 months and 12 months. They showed significant improvements in quality of life and dyspnea score. Interestingly, they didn't show a statistically significant improvement in 6-minute walk distance. Rate of pneumothorax was comparable to the Zephyr valve system. In this one, it was about 56% who required chest tube placement, but a little bit higher percentage required removal of at least one valve. And then there was one death in this study that actually happened due to a contralateral pneumothorax. It's questionably related to the procedure. There was one late death due to an abscess in the treated lobe. So both of these systems are now commercially available. We offer the spiration valve system here. We will typically evaluate patients in the interventional pulmonary clinic. We start out with complete pulmonary function tests to determine if they meet the pulmonary function test criteria. And then if they do, we move on to the high-resolution CT. We are the ones who order that high-resolution CT because it has to be done with a very specific protocol. But in patients who have predominantly emphysema, this is a procedure that we are now offering here. Now, something that's coming up on the horizon that they're currently working on getting the clinical trial together for is for chronic bronchitis. One thing that you may have noticed throughout this entire presentation, there's not really anything that helps with the significant mucus hyperproduction and with the chronic cough in patients with COPD. And in people with chronic bronchitis, that can be a huge lifestyle-limiting symptom and can significantly reduce their quality of life. So what's been developed is a liquid nitrogen-based system that delivers bursts of liquid in a radial pattern in the bronchus. And this is a controlled delivery system, so you deliver a controlled dose to each target area. And the thought here is that you ablate this goblet cell-rich mucosa that they've built up, and then as the mucosa heals and reepithelializes, it heals with more normal mucosa. So this is the Rejuvenaire catheter. And then this is just how the procedure is done. You basically get it into the target position, and then when you deliver the spray, it just delivers it in this radial pattern around the bronchus. Initial studies are very recent but have been promising. So the initial hypothesis-generating studies were actually performed in patients who were going to have that area of the lung resected for lung cancer. And what they showed was that when they did this on patients who then immediately had their lungs resected, the damage was limited to the epithelium. There might be some edema to the submucosa, but the damage was overall very shallow. And then at 14 days post-application, they saw completely healed epithelium and then normal submucosal architecture. So based on these proof of concept studies, they did a pilot study across 3 centers in Europe. These were presented in October at the European Respiratory Society. So unfortunately, they haven't put out the full abstract. But what's been reported in the medical news is significant improvement in cough, mucus production, dyspnea, and quality of life. So based on these data, there is a clinical trial currently being developed. They're not even to the point of recruiting yet. But the design is a prospective multi-center randomized control trial, and their control is actually a sham procedure. 40 to 80 years of age. They have to have clinically defined chronic bronchitis, moderate to severe airflow obstruction, and then at least 2 moderate or 1 severe exacerbation in the prior year. They have to be off of tobacco for at least 2 months, and the primary outcomes are going to be exacerbation rate and quality of life. This is a trial I'm actually pretty excited about, again, because we don't have that much that really helps with the chronic mucus hyperproduction in these patients. And so something like this that might actually improve their quality of life is something that I think all of us should be excited about for these patients. So with that, I'm going to end and see if anybody has any questions.
Of aspiration, of gastric aspiration, how does this balance out?
So in the trials that have been done so far, the balance was in these selected patients with hypercapnia despite optimal medical management, the balance was in favor of using nocturnal non-invasive ventilation.
2 quick questions. Thank you. I learned a lot. Just and was not aware of the cryospray thing. Can you comment on different delivery systems for bronchodilators, particularly the utility of NEBs versus MDIs? And then can you also say something about theophylline vis-a-vis roflumilast? Because it's the bane of my existence.
All right, so the easier question is the nebulizers versus MDIs. So studies suggest that as long as people know how to and are able to use MDIs correctly, MDIs are equivalent to nebulizers. So one of the major disadvantages of nebulizers is that they require significant extra equipment. They're not as portable as MDIs. And also, you're applying medication not just to the respiratory epithelium, but also to the nasal membranes, the ocular membranes. And this actually, with our long-acting muscarinics, can be a huge problem because the muscarinics, while there's not really significant evidence of systemic absorption with just inhaling them, if somebody has glaucoma and that muscarinic antagonist is getting applied to their ocular mucosa, that can significantly worsen their symptoms. So the balance of data suggests that education on how to properly use the type of inhaler you are providing is key. However, there's no evidence of significant benefit of nebulizers over MDIs as long as they're using the MDIs with correct technique. As far as theophylline versus roflumilast, The data on theophylline are, I didn't find them to be very good. So I kind of left theophylline out because it's not as well supported as some of our other interventions. But it's thought to have some PDE4 inhibition properties, thought to have some bronchodilation properties, may reduce symptoms, may reduce exacerbations. Are you aware of any literature that it's been done head-to-head with roflumilast?
That has the effect size about the same as the roflumilast, except for the wallet impact.
That's very true. There is a significant increased wallet impact from the roflumilast. So.
Yes, thank you for such a wonderful talk. My question is about the use of oxygen, and the several studies that you presented said that there was no benefit, and I was wondering if that included a benefit of the perception of quality of life or just a mortality benefit.
So the long-term oxygen therapy trial did include quality of life as one of its secondary outcomes, and in that there was not a significant difference between groups.
What's your prediction of what the impact of vaping is going to be with the young people over the next few years?
So that's an excellent question. It is an area of active research. Some of the data that I've seen coming out, so unfortunately we don't have the long-term data that we do with smoking and COPD because it just hasn't been around long enough. Some of the data that have been coming out do suggest that you see some of the same immunologic changes from vaping that you do from smoking. How this translates into long-term outcomes remains to be seen. Certainly the issues with acute lung injury from vaping are a significant concern, and again, another area of active research. Even now, I think there are warning signs, significant warning signs, that vaping is not a safe replacement for cigarettes.